Hello and welcome to the Spinal Cord Injury Forum. My name is Jeanne Hoffman and I'm a clinical psychologist in the Department of Rehabilitation Medicine and the director of the Northwest Regional Spinal Cord Injury here at the University of Washington. Tonight we are so pleased to welcome Dr. Bunnell. He's an assistant professor of rehabilitation medicine, and he's going to be discussing the UW-Medicine's post-COVID telehealth clinic, as well as what we know about COVID-19, and we're going to have a discussion about what that really means for people with spinal cord injury. So we'll get started with Dr. Bunnell presenting, and then he'll join me for a discussion. Thanks for being here.
Yeah, my pleasure. Welcome, everybody. Thank you for coming out tonight. As Jeanne said, I'm Bunnell, and I'm an assistant professor in the Department of Rehabilitation Medicine and have been part of helping to set up the post-COVID care for the UW system, especially with regard to managing the longer-term symptoms and effects on physical function in patients. And really also want to give a shout out to Julie Hodap and Jana Friedley, who have been really helpful, and Joanne Lewin, who has also been really helpful in that. So I wanted to give a very brief introduction to COVID and some of the basic considerations in SCI. This is not an exhaustive talk. An exhaustive talk would take an hour or two, but it was really more just to spark conversation and help to begin the conversation about what concerns you guys may have. So I'll go over the clinical characteristics of COVID and what it is. I think we all have gotten an education on that already. I'll talk a little bit about some of the post-ICU or an ARDS sequela, and especially with regard to physical function and weakness and other things, as well as cognitive deficits and return to work. And then we'll talk a little bit about how all of this relates to individuals with spinal cord injury. So as we already know, COVID-19 is a disease entity, and it's caused by the SARS-CoV-2, which is really just severe acute respiratory syndrome, coronavirus 2. Here's a picture of it on the right. And really important to know that transmission is primarily by droplets. It's not by the 5G cell phone networks, as you see sometimes on social media, or it's not from the shoes that you're wearing outside in the street. It's really from the droplets that are in the air. And that's why we're all wearing masks. That's why we're all staying separate. And the virus is really released from your respiratory tract, either if you cough or sneeze or you're talking, and then that travels in a droplet through the air and makes contact with a mucous membrane. And the main mucous membranes are eyes and respiratory tract. So one of the things that people are really trying to understand is, what does this disease do? And in the general population, I really wanted to start with this slide. Most people are going to get mild disease. So I think it's really important to take this seriously, but I also want people to understand that the likelihood if you get this disease is that it's going to be mild. And that's about 81% of people. We should note that this is general population, and we'll talk about some of the special considerations that occur in spinal cord injury. About 14%, which is not a small number, can get severe disease. So you can have shortness of breath, which is dyspnea, hypoxia, or more than 50% lung involvement, and that's as shown by imaging within 24 to 48 hours. And then the news media and what we see on TV a lot is these critical cases. And we see that at Harborview, and these are patients who are really, really sick. And we have seen that this is more than the flu. Patients going into respiratory failure, shock, multi-organ failure, requiring ECMO, which is just an ability to oxygenate the blood without actually breathing air. And best estimates right now are about 2.3% overall case fatality. So that, that number is probably going to change as we get more information as time goes on. It may be underestimating the deaths that we're seeing because, in this case, no deaths are reported among the non-critically ill cases, but we are seeing that there are some unexplained deaths that are occurring within the general population. So when you look at cases in the hospital, and this is out of New York, about 33% required invasive ventilation. So that just means you were put on a ventilator. In about another 30%, they required support for their blood pressure, so vasopressors. And among the critically ill, something called ARDS is the dominant finding. So ARDS is acute respiratory distress syndrome, and that ended up occurring in about 40 to 70% of the population, depending on which study you're looking at, whether it's out of China. So, that just remember that ARDS, because that'll come up later in the slide as we talk about effects of being in the ICU. So many patients are intubated for 1 to 2 weeks or longer and have a common complications. So acute kidney injury, thromboembolism, which just means blood clots going to the lungs, heart attacks, and strokes, and then also arrhythmia, sudden cardiac death. And as time goes on, we've seen that there's more evidence of inflammation of the heart muscles and fluid generating around the heart. And as you probably have noted in the news media, that comorbidities are associated with more severe illness. So if you have cardiovascular disease, you have diabetes, hypertension, chronic lung disease, cancer, kidney disease, obesity, or you're a smoker, those are associated with more likelihood of having one of these really severe cases where you're in the ICU. You'll note that spinal cord injury is not noted in these, but it might be that spinal cord injury is so rare that we're really not able to pick up that signal yet. And I think, why do we care? So, I think sometimes on TV, you go into the ICU, they save your life, you go home, everything's all great. But going to the ICU often has long-term consequences. So one of the areas that I study is the neuromuscular pathology in the ICU, and that just simply means damage to nerve and muscle. So when you look at critical illness myopathy or critical illness polyneuropathy, which is just muscle and nerve damage in the ICU, if you're underwent lengthy mechanical ventilation, if you're on the ventilator for a long time, about half of those patients will have one of those entities. If you are on mechanical ventilation for only 4 to 7 days, about 1 in 4 or 1 in 3 will have it on clinical assessment, so your strength will be weak. But if you look at it with electrodiagnosis, which is a way of looking at nerve and muscle physiology, almost half of those will have that. In ARDS, those numbers are probably a little bit more. And then if you're going longer stays in sicker patients, those numbers can approach 3 out of 4 or even 100% in some really sick populations. And what that really means is that you're not as functional. You're weak, your endurance is limited, and you're not able to do the things that you need to do to take care of yourself and be independent. And that shows up in other literature. So when we look at ARDS and people's endurance, at a year, about 6% of patients continued to have oxygen desaturation, so their oxygen levels in their blood would go below 88%, and normal would be at least 92, and most people 98, 99. The other thing was that their endurance was about 66% of what their predicted endurance would be for their age and for their sex. And the other thing is that muscle weakness and fatigue were the most common reasons that their function was limited. The other thing to note is that this symptom or this syndrome, the ARDS, can affect your cognition and other domains. So if you get ARDS, about 50% of those people that were working before won't return to work. And that's about out to 5 years. So turning to spinal cord injury, what's this impact in COVID-19 in patients with spinal cord injury, and I think also their caregivers because of that intimate relationship. So currently, we don't have extensive data. And before you read these sentences, I want you to know that I would not judge your risk of sickness based on these two case series. So case series are where somebody's in the hospital and they notice that they have a bunch of cases of COVID and spinal cord injury, and they say, hey, let's write a case series. But that doesn't give you an idea of the general population of spinal cord injury. It gives you an idea, a little snapshot of what they saw in the hospital. So just with that caveat before I terrify everybody. When you, in two case series, one out of Spain, and I think the second was out of Italy. In the case series from Spain, they had 7 patients. All the patients recovered. The presentations were pretty similar to the general population in terms of number requiring more critical care, the lengths of recovery, and the use of vasopressors and the patients with a little bit more mild symptoms. Another case series, they looked at 4 patients, and 2 of those ended up passing. However, it should just note both of those patients were very old, had multiple comorbidities, and were in very high-risk groups for other reasons. So that said, I think there are some considerations in spinal cord injury that we have to think about in terms of risk when you get this infection. So I have a spinal cord injury, and I actually didn't know before I went to medical school and residency that I had cardiopulmonary involvement. They were doing respiratory testing to teach us it, and then I did it, and they were surprised at how low my lung volumes were, and I was too. So when you have a cervical spinal cord injury, your ability to take in a deep breath and your ability to fill your lungs with air can be diminished. Normally people won't necessarily notice that, but if you get a severe infection, you might not have the reserve to overcome those symptoms. So, someone who is my age and got COVID but didn't have a spinal cord injury might have enough reserve where they got sick, but they never got really sick. Whereas if I got it, maybe I would get sick, but my reserve is not quite there, and the infection would be more severe for me. The other things that we experience is autonomic changes. So our heart rate may not be able to adjust, and this is usually for people that are, T6 and above. If you're a lower paraplegic, you may not have some of these sequelae, but the other things that can change are your abilities to manage blood pressure, and also changes in the way your lungs can clear secretions, and how your lungs, your airway diameter may be a little smaller or a little bit more bronchospastic, we say, so the airway caliber may close down a little bit. Additionally, spinal cord injured patients may have more comorbidities. There are other factors like aerosolized procedures like MIE or tracheostomies. And additionally, I think access to care is a big issue. So having access to care providers, transportation, I think is a big deal. So I think also there's some challenges reducing exposure, because some ways it's really difficult to socially isolate. If you need a caregiver to help you dress, or you need a caregiver to function throughout your day, then you can't say, I'm just going to socially isolate. You need that person to come in and help you to function. And you may not be able to drive on your own. You may need to take public transportation, or use transportation which does not allow you to socially isolate. So those are some basic conversation starters. I think to really dive into the issues, I provided some of the resources that are out there. The CDC has extensive guidelines for managing infection risk, PPE, and guidelines for hand hygiene, et cetera. And then I also provided some publications just for disability-specific concerns from the World Health Organization. Thank you very much.
Thank you, Aaron. That's great. And I feel like now I have a dozen more questions.
Yeah, I expected that.
Which you knew. Just to kind of talk through a little bit more about kind of the lung function issue, because that's an issue for a lot of people with spinal cord injury. not even people obviously on ventilators, but people with just higher level spinal cord injury, cervical spinal cord injury. Are there extra protections or extra things that people should be doing? I think, we all hear a lot about kind of PPE or personal protective equipment, but I think that there's always that question is like, should certain people be doing more?
Yeah, I think, if it's going to be a little different if you're a low para and you're 21 years old and otherwise perfectly healthy versus a high-level cervical spinal cord injury. Maybe it took you a long time to wean off the vent and you experience some air hunger and it's really hard to get a deep breath. I think you have to assess your risk a little differently. And in that higher level injury, your risk and capacity to overcome an infection may be decreased. I don't think we know exactly. And you might be fortunate and get one of those mild infections and everything's great. But if you got one of those more moderate infections or severe infections, it may have long-term effects for you. In terms of what you would do, I think just being more cautious, really assessing, do I need to go to the grocery store to do this errand, or is there another way I could accomplish that? I really want to go to my cousin's wedding, but how much of a risk is that? I think those are all questions that come up. So in terms of the PPE, I think you may want to consider, we hear a lot about masks in the media, but eyeglasses are also, and eye protection are also an important part and can keep some of the droplets from contacting the mucous membranes in your eyes. The type of mask you're using matters. So this is also evolving, but using N95 is the best kind of mask. Those are really being reserved more for medical professionals at this point. The second level is more medical masks, surgical masks, and then the cloth masks. And some of the CDC guidelines that I provided give you more details on what type of cloth masks and how to use those.
Yeah, that's great. I think that, I think everybody should be wearing a mask when you're out around other people. But I appreciate that added eye protection, especially if you're at a higher risk, is really important. And, for those who aren't in medical settings, I think at this point, like throughout UW Medicine, we all, if we're involved in patient care at all, we're wearing eye protection. So it's not like you won't be around people if you come to the doctor.
Absolutely. And then the other thing is just to consider hand hygiene. So I'm providing a bad example, touching my mask. But you should be, as if you're able to practice hand hygiene, to use either alcohol gel or hand washing to make sure that that's not being transmitted to you. So that goes for whenever you're touching other surfaces or out in the community. If you have to get through a door, you should be using hand hygiene and avoiding touching your eyes and mouth after that. And those behaviors are actually some of the most important ways of reducing risk.
Yeah, and I think those are hard for a lot of people to get into new habits because we're not used to doing that. I know that it's one of those things of having to really keep hand sanitizer everywhere.
Absolutely. And I can't tell you the number of times I left my car, got about halfway to the elevator, and was like, damn it, I forgot my mask, and I gotta go back, and oh, now I gotta get my glasses. And now it's like a habit, but it took a little bit.
Yeah, but it takes it, yeah. Yeah, I was gonna say one day I got all the way, like almost to my office and was like, what did I do? Panic.
Now I feel naked without it.
I know. Kind of crazy. It does bring up the access to healthcare. I think one of the things that I've actually heard from several people is real concern about seeing their doctor. And yet, I say this to a lot of people, I feel very, very safe in the hospital, in the clinics, because I'm around a bunch of people who know this stuff and kind of know what to do to protect each other. What advice are you giving to people about seeking out health care?
Yeah, that's interesting because the most terrified I've been is out in a Quickie Mart in Cle Elum, where everybody was not wearing masks and like chatting and coughing, and I was like, wow, this is a dangerous spot. And I agree with you. I feel more safe going into Harborview where everybody's being careful and cautious, and I can trust that if they've had symptoms, they're not coming in, than I do in the community. How I would structure it is if it's an issue that can be taken care of over telemedicine, then do that. But if it is something you need to see your physician for, I think it's okay to come in. I think the risk is not so great that you should avoid medical care at all. If you're having some shortness of breath or chest pain, you need to go into the hospital. If you're having, you think a severe infection of some kind, go ahead and go in. But if it can be taken care of by telemedicine, I think it's a great option. And we're discovering we probably could have been taking care of a lot of things by telemedicine before. So.
Yeah. I was going to say, I think this has helped move that forward much more quickly than we ever would have anticipated. And I think that, that's also, if people are unsure, to try telemedicine first, if they're uncomfortable, and to have that conversation with your provider, because they can tell you whether they think they need to see you in person or not.
Absolutely. Yeah, they can give you some guidance and tell you, I really have to see you to take care of this, or we can do this by phone.
Yeah, absolutely. So, in terms of thinking about kind of people in the hospital with spinal cord injury, are you aware of or seeing anything different about how these patients are dealt with, or how, again, like you said, we're not seeing a lot of numbers, but it's also a rare disorder in the scheme of things. Is there things that would be different?
And are you talking about spinal cord injury patients that have COVID? Or,
well, I was going to say either have COVID or just need to be in the hospital.
Yeah.
I think you're right. There is two different kind of pathways.
Yeah, and I've not had a patient yet with spinal cord injury who's presented with COVID. In terms of patients with spinal cord injury that need to be in the hospital, there really was a difference early on because we weren't sure what the transmission rates were and if we were protecting patients and staffs. And so there was probably less direct care being delivered. I think that's changed back now, and it's largely normal. The main differences are you won't see providers without masks and gloves and eyewear, and you're not going to see, you're probably not going to be out in the halls as much, or being taken to the visitor the viewpoint, or having a lot of visitors come see you. Those are differences in care, but you can still get physical therapy, you can still get nursing, you can still get care delivered.
Yeah. So talk to me a little bit about what people need to be thinking about at home with caregivers. This is another area that I've talked to several people about who really, initially kind of stopped having people come in who were helping more than one person. And so kind of where are we at in terms of thinking about how to work with caregivers most effectively and most safely?
Yeah, I think it's really a challenging thing because you do need the care, and it's really hard to function without it. Yeah. So part of this is a trust dynamic. So having that frank conversation with the caregiver that if they are having symptoms, and that includes, fevers, chills, shortness of breath, cough, gastrointestinal symptoms like diarrhea, muscle aches, anything like that, they really should not come in. And that goes also for if anybody else that they're caring for has those issues. I think if they're practicing good PPE wear, good hand hygiene, that the risk of having a couple people they're caring for is not as great as if they are participating in community events that are high transmission risk. So I'm actually more worried about them going out into the community and going to bar night or going to their buddy's house and hanging out with 15 people than I am about them seeing 3 or 4 patients in their homes, because those home settings, the number of contacts that are happening are not as much. Ideally, it would be that you have one caregiver who is quarantined and only sees you, but we are also having to, make some weighing of risk, like the care versus the risk of infection. So I think you're going to have to navigate
and
that.
most people don't need full-time care, and that means that caregivers are working for more than one person. So,
Yeah.
so it sounds like interviewing your caregiver and really talking through and having that very frank discussion about, what are you doing in your free time? How are you being safe? How are we going to protect each other?
Yeah, I think, and some of it comes down to your trust of the caregiver, and truthfully, it can be hard to find caregivers. You may not have the highest level of trust of your caregiver. You may have one that's golden that you just completely trust. But I think having that frank conversation with them that, look, if I get infected, it could be really serious, and I hope that you're being really careful in the community and not increasing your risk, but also just to know that with me, it really could be very, very serious.
Yeah. So in terms of PPE use, I mean, I know you and I both have gotten to watch the video and maybe even try all the stuff on. But, we go from masks and eye protection to masks, eye protection, gloves, gowns. Do caregivers need to go to that level?
Yeah, I would definitely go. So the eye protection will protect them from you more than you from them.
Right.
But at least the mask, and I would say the gloves too. The other thing, as I mentioned before, was that they should be practicing good hand hygiene. So if they're about to feed you, they should be gelling up before they do that, and then gloves. And I would recommend that they wear eye protection. I think that's a good idea. But I don't know if that's as essential for protecting you as a patient from them. The mask, absolutely.
Yeah. And I think masking for you to mask with them as well, if they're not doing something like helping with feeding or helping with oral care or vent care or things like that.
Absolutely.
Yeah.
And I think I would also, for you, I would wear glasses, some kind of eye protection, as long as it's not being bathed or something like that.
Right. And there is no specialty in eye protection. It's just some clear lenses that kind of wrap as best you can.
You want as much coverage as you can. I mean, you can see there's full face shields, which are probably the best, but sometimes a little bit impractical, like if you're going to try to eat or something like that. And they can also become a little bit tiring to wear. I can actually wear this pair all day, and they give a pretty good wraparound effect. There's lots of options on Amazon for 10 to 12 bucks, and I think try not to get the ones that are too narrow. Get ones that actually cover quite a bit.
Yeah. And remember to wipe them down.
Wipe them down and don't touch them all the time.
Don't do what Aaron's doing.
Don't do what I'm doing. Demonstrating exactly what you shouldn't do.
We all do it when we're demonstrating. Yeah. We don't do it when we're at work.
Yeah, when I'm working, I'm pretty careful.
Yeah, we're very careful. I'm curious too about temperature checks. That's what I was thinking of. So one of the things that people are surprised of when they come into a UW medicine facility is they don't get a temperature check. But fevers are only in some portion, right?
Yeah, so I would say that symptoms are more important than the temperature check itself. Temperature checks are better for people that are trying to get through airports that have symptoms. It's pretty rare to have a fever and not know it. So if you trust your caregiver to tell you their symptoms, then that's going to be enough. Unless you're the one doing the temperature check and you're trusting their judgment on the temperature check, it's pretty equivalent. So I think giving them and I can provide a list of symptoms that people should be screening themselves for before they come in.
Yeah, that's helpful. With that, I think there's this concern about people not having symptoms, right? That they're carriers, that they could pass it to you. I haven't seen the kind of most recent numbers of where they think the number of people who don't have any symptoms at all versus have mild symptoms and don't think that it's COVID-19, but actually is COVID-19, right? I mean, I think this becomes really complicated.
It's a really hard number to estimate because you have to do large population studies in patients you didn't think they had COVID, right? So,
Right.
And the numbers that I've seen are anywhere from 20 to 50%, but that I think those numbers are going to take a while to really work out.
Yeah.
It is a huge concern because there are patients that are symptom-free. I think some of that is coming from people are not identifying symptoms, like they have stomach upset or diarrhea, and they're not identifying that as COVID.
Mm-hmm.
Or they have a slight runny nose and they just think they have a cold. So I think being vigilant about symptoms is really going to be key too.
Yeah, absolutely. The other part of that is on the other side is like if somebody has had COVID, there's this question about how much are they now protected? Like, do they need to keep doing all the extra stuff if they've had it and now they've recovered and they're on the other side?
Yeah, so that's another area we don't fully know yet. There are a couple of case reports of people who have had second infections, and we don't know what your long-term immunity is to this entity yet. So I would say that if you've had COVID, that you should continue to be vigilant.
Mm-hmm. So keep doing all the same things.
It's not time to just run out and enjoy exactly as you wish. So I think I would be careful.
Yeah. What about like for people who need to go out for or are being recommended for like physical therapy, occupational therapy, speech therapy? Is it better to have people come into your home? Is it better to go to an outpatient setting? What would you recommend to people?
Yeah, that's a tough question, I think. Home settings, I think, can be really helpful. The numbers of patients that they're probably seeing are fairly equivalent. The one advantage is that you won't be exposed to additional risk of going into the hospital, maybe being in a clinic where you're socially distanced, but there may be another few people around in the general vicinity. So I would say overall the home is probably more safe as long as the quality of the therapist coming is great and that they're cognizant of their PPE and their own distancing. I would say that I trust the Harborview therapists greatly because they're just smart people and really dedicated. So I trust them greatly. And some of the studies coming out from the early outbreaks in skilled nursing facilities and other places were that the staff really wasn't well trained for PPE use. So you just want to make sure that the home health agency or the therapy that was coming to your home was well trained.
Yeah, and so talking to people, asking questions.
Asking them questions, what are your procedures? How are you making sure not to transmit infections? I think that's all pretty helpful.
Yeah, those are kind of tough, but probably really important right now is to be really clear about what it is you want somebody to be doing.
Yeah, I think just having frank conversations with people, these are conversations that we didn't really have to have, outside of our other intimate relationships, and I think it is a little awkward, but I think it'll lead to a better understanding between people. So.
Yeah, and I keep telling people, like, we know so much more than we did in March, and by March in 2021, we'll know so much more than we do right now, and it's just this really amazing group of people who have been figuring it out already, and yet there's still a lot that we really don't know.
There's a lot of unknowns, but you're right. The level of knowledge has grown quite a bit. So I think you're right. By next March, we'll know a lot more.
Yeah, yeah, and we'll still have a ways to go.
Yeah.
In terms of kind of recovery issues, I mean, you're in this clinic now, and are you only seeing people who have had ICU stays or just people who have had a diagnosis of COVID and are having ongoing symptoms?
So we initially started with patients that were hospitalized with COVID. So if you got to the acute floor or to the ICU, then you were sent to our clinic for follow-up. And we screened a number of areas, so your endurance, your ability to function, your ability to think, your cognition, and then your mental health, so PTSD, depression, things like that. And now we've opened it up to more of a community-based system. So if you're having ongoing deficits, that you can come into our clinic. And we were looking through some of the numbers in another study that's outside of that clinic, and finding that even in the younger patients, I think the range was 21 to 65, that around 30% of those at 1 or 2 months were still having problems walking a quarter of a mile, and then about 50% of the patients that were older were having that issue. 50% of the younger patients were having trouble going up several flights of steps. So quite a bit of endurance issues. And then other patients noting new functional limitations, so difficulties transferring or bathing or getting tasks done around the house. So I think that follow-up is needed for a lot of people.
So can't just assume that even though you didn't end up in the hospital that you won't still have some longer-term effects. And I guess we don't really know kind of what the true long-term, because we're still in the early phases.
Exactly. I think the patients in the hospital clearly are at higher risk for long-term effects, but we are seeing some patients that are having ongoing endurance or shortness of breath or feeling fuzzy as they think. All of those issues are coming up for people.
Yeah. And I realize that I don't know that I've seen any research, but you obviously are much more well-versed about predicting. I mean, there's the clear predictors of people who have comorbidities who are likely to do worse. But we've all heard stories, and certainly we've had patients in our system who don't meet those criteria.
Yeah.
Is there any clear guidance about who ends up beyond the obvious, like if you were already compromised, that even a bit of infection could be problematic? Is there any sense of kind of why somebody who's otherwise healthy gets a severe form and actually may have long-term effects or not?
Yeah, and that research is also ongoing, and you're right that there's been some patients who have been really vigorously healthy with no apparent comorbidities. So
Right.
like one patient I knew was benching like 350 pounds, running all the time, really fit, but then got a very, very severe case. And they are looking at genetics and blood types and other factors which may be contributing, immunological markers, and the body's response to the disease may actually be part of the problem. That's the severe cases actually may not be so much COVID-19, the SARS-CoV-2 virus, but actually the body's response to the virus that's the issue. But I don't think we can definitively do a blood draw and say you're a patient that's at a high risk and you're a patient that's okay. So
Yeah.
maybe over the next year or so we'll know that.
Yeah. That's more to come, right? That's on the more to come list.
Yeah, and the other things that are happening with people, the patients that are having heart attacks or blood clots or peripheral neuropathies, we don't really know which patients are at risk for those and who it is that's going to get the most of those. Those are things that we're noticing right now, and after you've noticed it, then you can go to the next step and say, okay, so who's at risk for these different types of sequelae?
Yeah. So lots of people doing a lot of research in this area.
Yeah, there's a lot of research going on right now, and lots of groups that are addressing this problem.
Yeah. One of the pieces that I think we've all seen is that, from where we started in March, there's actually possible treatments. And so, there's some sense of that we're protecting people better, and we know how to do some things to ameliorate some of the symptoms and keep people alive, or potentially keep people healthier. The next step is that vaccine thing. And I know that this is not your area of expertise, but, I think that, I think about like who gets in line first, and do you want to get in line, and should you be in line, right? I mean, those are those questions, right? Like, we want to be equitable about who gets it and who should get it first. And so I'm curious about kind of your thoughts about, like, where do we trust it? How do we know to trust it? And if we know to trust it, when do we get it?
Yeah, and I can just definitely emphasize that this is not my area of expertise. I don't develop vaccines or.
But you knew I was going to ask anyway.
Or I don't, I don't roll them out and
Right.
and I don't do the studies on vaccines.
We don't do vaccines in rehab medicine.
Yeah, I'm not a vaccine expert. I think there is, the most likely people to get this out as a first line are going to be people that are directly treating patients with COVID. So, all of the people at the front lines are the most likely because partially their risk is higher and the risk-benefit ratio is better because of that. The next line, that's an interesting question. So if you're at higher risk with multiple comorbidities, your risk of having a severe infection is higher, so you're probably more likely to be a candidate for that vaccine. That said, there are some drawbacks. It depends a little bit on how well the vaccine is studied and how early we are. So, and in my sense is that because of the massive implications of this virus, that we will probably maybe not do 5 years of testing to make sure the virus is completely safe. So there may be some risk initially, but they are doing very large studies, so you can know that that risk will be small, but it may not be 1 in a million, it may be 1 in 1,000 kind of risk. So yeah, there is some. That said, I personally will probably get the vaccine if it's approved through a decent study.
Yeah. And I think that's the big question is the research done right? And I think, my goodness, is it getting a lot of scrutiny? So we'll certainly hear everybody's opinion about it.
Yeah, there are people that I trust, like Fauci, people like him I think are actually looking at the science, looking at the research, and trying to make a good decision based on the population and the risk-benefit ratios. So, there are people that I trust, and I would look, personally, I'm going to look to scientists and people that, are not connected to pharmaceutical companies and, actually evaluating the research as objectively as possible. And science is an iterative process. We're going to learn more as time goes on. You're not going to know everything with the first study, and we'll learn more as time goes on. But I think, we'll trust those kinds of people early.
Yeah, I think it's so key. I sometimes get the question from people of like, well, why are we doing X now? We didn't do it 6 months ago. And it's like, well, we know more. I mean, this is kind of the cool thing about science, and the hard thing about science is that when we know more, and then we can change what we're doing, and we can rely on really smart people figuring things out.
That is exactly right. It's the great thing about science, but it's the frustrating thing is these slow incremental changes over time. I mean, if you think about like the 1950s, when you had a heart attack, you were in bed for a month. They just laid you down, and they discovered that when they had a little bit of a resource crunch, that the patients that actually got up did much better. So that bed rest for 30 days. I mean, this is also true of pregnancy. So you got a baby, 30 days of bed rest. Like, wow, what a way to make someone sick. Yes. We look back at that, but that is the scientific process of like, what's the actual effect of what we're doing.
Right. I mean, there's all those great posters of doctors recommended smoking. So.
Yeah, exactly. I know. I kind of wish I was in the cool old days of rounding while you're smoking, thinking. But
smoking
yeah.
in front of your patients.
And I would say also, there's a lot of media out there, and I was losing even more hair watching these hydroxychloroquine, where they would bring out some random study where a bunch of guys looked back at their records through the hospital and these retrospective studies, and then they would make some conclusion trying to adjust for the variables. And those studies would be held in equivalence to randomized control studies that were really well done. And it was just very frustrating to watch the media report each study coming out as if it was equivalent without any assessment of the level of evidence. And I think being really cautious about studies that come out with 10 people or are retrospective versus randomized, that those studies are not well done, and sometimes the media will report them as if they're the same. So when you're looking through your Yahoo news feed, like if you're old like me, or your Twitter news feed, if you're looking at those kinds of studies, really try to assess the evidence. And if you don't have a ability to assess that evidence, I would try to look deeper into other resources which can help you do that.
Yeah, I was going to say that's a hard thing to do, and I think it's also probably reasonable to talk to your providers about it, because a lot of times healthcare providers are at least paying attention. They may not be as easily able, but they have been talking to their colleagues who are the scientists and trying to figure things out. And certainly, we've just are lucky here at UW Medicine to have really smart people trying to help us all figure all of those things out.
Yeah, it is really great to have the knowledge base of all the colleagues that have done the studies and know how to assess the evidence. So.
Yeah. So a couple more things kind of specifically in spinal cord injury. Pressure injuries are pretty common for people, and if somebody has a wound of any sort, does that put you at increased risk, having a space for an infection to grow?
Yeah, so I was actually looking this up this week, and there is some risk of viral transmission in open wounds. It turns out that wound dressings are pretty great at preventing viral transmission. So as long as the wound is dressed, that you're not at increased risk of having that transmission. Mm-hmm. There is that period where you're, doing wound care that you may be at some increased risk, but it's not. It doesn't look like it's as high as respiratory or eyes.
And is there anything specifically? I mean, we talked about lung function and all those kind of pieces.
I'm sorry, just to be clear, there are no case reports of COVID transmission through wounds, but there are other studies of viruses and how they can be transmitted through wounds.
Right.
So I just want to be really,
clear.
Clear
Nothing to show
before I send
COVID-19
everybody
at all.
off on another tangent. So sorry.
Perfect.
Yeah,
No, perfect. It's good to keep clarifying. The other question that had come up that I wanted to make sure we covered is there anything, and you didn't mention this specifically, so I want to specifically ask about immune function. Is there anything about having a spinal cord injury in and of itself that changes your ability to fight infection?
Yeah, and there are some studies which suggest that in spinal cord injury, some of your innate immune response may be altered by the spinal cord injury itself, and that can also be connected to the autonomic nervous system and the body's responses to virus. So it's interesting because that could either be a minus or a plus, because if your body's not reacting as hard to a virus, then if it's the reaction to the virus that's causing the pathology, that may be a plus. But we don't really know, and specifically with COVID, what is happening with spinal cord injury.
Yeah, that's helpful. And again, more to come. I mean, we'll learn about this stuff.
We will learn, and eventually there will be enough patients with spinal cord injury that will be able to better describe, their response to COVID when they've, contracted that. So.
Yeah. Should people go and get testing just because?
I would say no, not without symptoms.
Yeah. And if you have symptoms, probably worth getting tested.
Yes, then I would get testing.
Yeah.
Call your doctor and get an appointment, and you can arrange testing that way.
Yeah. I think it's good to know if you are having some symptoms, because it can help decide what to do.
Yeah, and it can also help to stop the spread to other people, to think about caregivers who might be treating other patients who, you really want to think about not only yourself, but your community. And it will also help your doctor to assess your risk and what they should be thinking about as you develop further symptoms.
That's great. So I want to open it up to our audience now to ask other questions. So the question was, for those people who do have some concern about compromised lung function, should they be doing something in particular to improve their lung function right now? Should they be trying to exercise or do breathing exercises of some sort?
Yeah, so there's this concept of prehab for people that are about to undergo procedures or undergo some medical intervention that may be physiologically demanding. And absolutely, I always recommend exercise, and that's a way to improve not only your cardiovascular function but your pulmonary function. I think if you were to contract any kind of infection, you really want to be vigilant about MIE, bronchopulmonary hygiene, getting things cleared, and then also talking to your doctor about other potential interventions such as nebulizers and airway caliper increasing agents like albuterol, or just making sure that those other options are explored with your physician. So it's funny because I think I did this in the spring. I was worried that I might get COVID if I was at Harborview, so I started really working out on my bike a lot to try to build my fitness in case I did get it. Because I do think, if you can imagine, there's a certain hurdle for COVID, and if you can get your fitness up enough that if you got it, you were able to cross that hurdle, I think that's a reasonable intervention. That said, if you're not, I think sometimes it's really hard to get the levels of exercise if you're a C5 or C4 tetraplegic. It can really be hard to get fully the cardiovascular load. So I wouldn't spend your life terrified because the pulmonary function is not there. So
yeah,
do what you can.
Yeah, and then protect yourself.
That's right.
Yeah. So the question is, if you're wearing a face shield, do you wear a mask too, or is a face shield enough?
Yeah, so I recommend wearing both if you're going to do it. The face shield does give you some protection here, but there's actually a lot of aerosolized particles that can come up through and underneath it.
Yeah.
It does give, I mean, I've seen some amazing ones that go down to like your knees, and I'm not sure that's if you have to wear a mask then. I saw one out in the grocery store. I was like, this person's going all out.
They're wearing their bubble.
yeah, almost a bubble. Like it went down to the knee level. I was like, why stop at the knees? Go to the feet.
Yeah.
But with the general face shields that are going down to chin level, yeah, I would absolutely wear a mask.
Yeah, and I think the times that we say you can go is if people have some reason why they can't wear a mask. But again, better to try and do both if you can.
Yeah, and I think in the media I see a lot about masks causing elevated CO2 or desaturations for your oxygen levels, which that is hooey. So
I was going to say, I hope none of those people have ever had a surgery because their doctors have been wearing face masks for hours.
Exactly. Yeah.
Performing delicate surgeries.
My surgical rotations in med school, I wore masks all day long, and I agree that it can be uncomfortable and it can cause some facial acne or whatever, but you don't have to worry about your oxygen or your carbon dioxide levels.
Yeah. So the question is, can you tell that you have COVID if based on pulse ox levels?
That's a really interesting question. So clearly desaturations are common with COVID. I've not seen anything where people have detected COVID using pulse ox alone. My suspicion is that by the time that you're having desaturations, you would not be asymptomatic. So you're most likely to be a little short of breath or at least coughing something up, or I would be very surprised if you're having desaturations without symptoms. And one other thing just that I haven't mentioned is that there are situations where it is where you just have to take the mask off. You're doing oral care for someone who needs it, or MIE. The next step is also just to make sure that the room is well ventilated. That's been shown to reduce transmission rates. So as long as the room is circling air through, that can help.
Yeah. So even though it's chilly, open the windows.
Yeah.
Open the doors.
Go ahead and run the ceiling fan or
Yeah.
whatever you need.
So the question is, if you're on an immunomodulating drug, are you more or less at risk for COVID?
Yeah, so what I've seen is that, there's many different immunomodulating drugs, so you may want to talk to your provider specifically about the one that you're on. But in general, I've seen that immunomodulating drugs are considered to be a risk factor for getting COVID.
So the question is kind of, how do you keep equipment sanitized? How do you manage hand hygiene in a wheelchair when you are, like, how often should you be doing hand sanitizing when you're in your wheelchair, when you're touching, obviously using all the parts? I would guess this would be even with a sip and puff too. So curious about just how do you stay safe and sanitize?
Absolutely. And that's a great question, and I would say frequently wanting to disinfect surfaces that you're repeatedly touching, and that is it's different if you're at home alone and you've been isolated, and your risk is probably pretty low. But if you've gone into a public setting or your caregiver has come in, any of those transitions where you're introducing new elements, you want to be disinfecting again. So, if you've gone out to the grocery store, then it's time to disinfect the equipment that you've used in that setting. If you're just at home, I think you can do kind of normal routine, disinfect once you got back home and then return to your routine. Other things is just being mindful when you're in public settings with doors about your eyes and your mouth and food, that you're making sure that you're disinfecting before you're touching any of those surfaces. And then the other thing is just mindful of your mask. So after you've had your mask in the public setting, and you should be taking it off by the straps and not by the mask itself, and not touching the mask and then touching other surfaces, because that could have trapped some of the virus in that surface. And I was thinking this week about the contact of the wheelchair on the ground, and did some preliminary investigations through the CDC. They don't have the wheels specifically, but they talk about footwear and walking on surfaces out in the community, and they think the risk of that is pretty low. Extrapolating, my guess is that the risk, if you're in a community setting and wheeling through the community, that risk is fairly low. You might, when you get home, disinfect the chair and disinfect the handrails. And a Clorox bleach wipe would work for that, or alcohol wipes.
Yeah, I think I like that. Any transition. So out, in, even at home, in and out of your wheelchair might be a good time. If you're transferring from bed to chair, wipe it down before you do that transition.
Yeah.
And then make sure you're doing hand hygiene once you get settled.
And that's exactly right. When I get home, like, my kids don't hug me. Like, giving them a complex. So like I get home, and the first thing I do is get clothes off and get cleaned up, sterilized, or disinfected, and then return to more normal life.
Yeah.
But my shoes are remaining in the garage, and I'm careful not to touch surfaces as I come through the house as I'm able, and then we disinfect stuff.
Yeah. So should caregivers be masked throughout their time with you, or can they take their masks off if they're not within that kind of 6-foot social distance?
Yeah, I mean, it kind of depends on the architecture of the house. If you're in the same room, I would say you should both be wearing masks. If you have a giant house and they're the far distant corner of the house and they're going to eat lunch, I think that's fine. But if you're in the same vicinity, in the same space, I think you both should be using masks. And like the 6-foot rule is not perfect and magical, right? Like there is some risk. Like even we are taking some, level of risk here, being less than 6 feet or being 6 feet apart.
Right.
But so I think sometimes people think, well, it's over 6 feet, so I don't have to wear a mask. But I would say if you're indoors, you really should be trying to do that.
So this is a tough question. So if you rely on public transportation, but you're having symptoms, what do you do to get tested for COVID?
That's a tough question. My recommendation would be that someone close to you, and this is with full recognition that some families don't have a wheelchair van or other systems with which to do that. It's also possible that we could get a home health nurse or somebody out to you to get that testing done. So what I would do is call our clinic and we would try to figure out a way for you. I thank you for not going on public transit. Yes. Like I think infecting 30 other people to see if you're negative that's a no-no. So I really appreciate that.
Yeah, it seems to me that we're trying to do a lot of things within our area about reducing risk, and so contact the clinic. Yeah, that's a great question. How do you protect yourself from all those kids who are, some of them who are getting back to school, who are going back into public? How do you make sure that you're safe from them?
Yeah, it's a challenge, especially, in families where affection is natural, being in the same room is natural. My family made the decision not to send our kids back and to do tele-education, which obviously has some of its own drawbacks for that reason. I think, again, it's a conversation with the kids, and my kids are pretty good about understanding some of what's happening and having a serious, almost adult conversation with them. Again, those transitions are important, so coming home, would recommend going straight to the bathroom, showering for the kid, and disinfecting before hugging you or spending a lot of time in the common areas, and that maybe having a spot where clothes can go that are separate from places that you're going to come in contact with. So trying to make sure that transition minimizes risk as much as possible. That said, I think it's really a challenge. So I recognize that.
Yeah, I think setting up a plan is probably the best thing that people can do, especially with kids of younger age, of just really developing a bit of a routine. Because, I think that's been hard for a lot of people. Some people don't have the ability not to have their children in school, in care, outside the home. And so it's really that balancing act of trying to figure out how are you going to do this safely.
Yeah, absolutely. And some of the studies coming out are indicating that maybe kids are not as bad as in terms of propagating the virus. I think we're still learning that. College students are, on the other hand, seem to be terrible and are more worrisome.
Yeah.
So.
Well, and I think, this isn't really related to spinal cord injury per se, but I think, we talk about COVID fatigue, right? People caution fatigue, they're COVID fatigue. People are tired. They're tired of being separate. They're tired of being isolated. They're tired of maintaining these distances. They're tired of mask wearing. We know on the news that there had been an outbreak on a unit in Harborview, right? And it's, people are being asked to be careful all the time. And that is a really tough thing to do. And yet we know that we're not in the clear, and we've got to get to the point where a vaccine is effective and enough people are vaccinated that it actually makes it effective. I don't know. Do you have advice for people about how to handle that caution fatigue, how to handle that COVID fatigue? I mean, what are you hearing at Harborview? Because obviously that was a big issue.
Yeah, it's real. And I think just recognizing that 2020 is a hard year and this is tiring. Like I was telling my family that I really miss just going to coffee shops and sitting and reading, and just that for me was a great joy. So one, I would address the fatigue and the mental health directly. If you're really having depression or just exhaustion, then finding providers that can help to mitigate some of that. Two, I would say that trying to find ways to enjoy life that are also within reasonable amounts of risk. So, if that's just going out to your balcony once a day for a little bit just to get some fresh air and be quiet, whether that's meditation, whether that's getting out into nature if you have that opportunity or that access. I think all of those things can be helpful. We've been doing Zoom calls with grandparents. We miss seeing them, but that's just been difficult. We've also seen people that wanted to spend more time together form pods where they've agreed that they won't see anybody else, but they're going to have a little pod that's there. I think that's a very reasonable strategy. So there are ways to try to be creative about reducing the drag that is 2020. I mean, like, just to be honest, I find it exhausting, but I think we got to keep that endurance up just for the health of our population and ourselves. So.
Yeah, I mean, this is just, this is a public health issue. It's not just you. It's not just me. It's everyone trying to keep everybody healthy.
Yeah.
So we can move through this and get to the other side of it, which is really important.
And if you think about it, your efforts may have actually saved somebody's life. So you're dealing with all of this, being isolated, missing friends, all of that may have actually saved somebody's life. And it's possible it saved many people's lives, because sometimes if you're the single beginning of a transmission, that can spread to many, many different people. So just think of yourself as a hero and a lifesaver. Maybe that'll help.
Absolutely. I definitely appreciate that.
I think it is heroic.
Like, it really is. I mean, I think
tough.
Everybody who's kind of doing this day in and day out, whether you're at home, keeping socially distanced and being safe, whether you are having to go to work or not, or working at home or managing your family, I think it is all heroic at this point. And, figuring out ways to be resilient and figuring out what you have control over and what you don't have control over is really, really key right now. So I agree. Ask for help. Look for your people and how you can connect with them, whether you can find a safe pod, whether you can connect via, video or pick up the phone the old-fashioned way. Email, all of those things are great ways to stay connected, even though we have to remain distant. Aaron, thank you so much for having this conversation and for your presentation. This is a tough topic that we know way more about, but we are still going to learn. And so we might need to bring you back in 6 months or so and see what else you've learned since then.
I'd be happy to come back. Thank you for having me here. Much appreciated.
Thanks, Aaron.
Thank you.
Thank you all for joining us tonight.